So thank you, the chairpersons and the speaker for this session. We move on to the next session, again on portal hypertension. And for this, I would like to invite our chairpersons, Professor V.K. Dikshit from IMS Varanasi, Dr. S.P. Mishra from MLN Medical College, Prayagraj, Dr. Sudhir Maharishi from SMS Jaipur, and Dr. Varun Gupta from Patil Hospital, Jalandhar. Over to the chairpersons.
Okay. So I would like to invite the first speaker, that is Dr. Naveen Kalra. Naveen Kalra is professor of radiodiagnosis in the PGI Chandigarh, and he is going to speak on the MR elastography and port application.
Good afternoon, everybody. And at the outset, I'd like to thank INASL, especially Dr. Ajay and Dr. Sunil, for having me here for this meeting. So I'm going to talk on MR elastography for hepatic fibrosis and portal hypertension, concordance with other modalities. MRE is even new for us, and we've started practicing it since the last 1 year or so. So chronic liver disease, we know, is characterized by replacement of normal hepatic tissue with diffuse fibrosis. And previously, the only method of staging the degree of fibrosis was liver biopsy. But to be optimal, a liver biopsy ideally should be 2 centimeter long, should have 11 portal tracks, and it is an invasive procedure. It has a complication rate. There is variability in microscopic evaluation, and the tissue represents only a minuscule part of the liver volume, which may result in sampling errors. So it may not be a very perfect reference standard. So elastography, the ultrasound strain and shear wave imaging has been around for a while, and MRE is the another technique which can be used. So elastography, a technique to evaluate the mechanical properties of tissue according to the propagation of the mechanical waves. And ultrasound or MR is coupled with a device that generates the shear wave within the tissue. The shear wave velocity is measured, which is directly related to the stiffness of the tissue. So if a tissue is hard, the propagation is faster, and if the tissue is soft, the propagation is slower. Ultrasound has widely available, widely used, readily accessible, relatively inexpensive, without any known adverse bioeffects. Only thing, it is operator dependent and difficult to scan in obese patients and in the presence of air. But we know that there are two types: the strain, where we just compress, usually used for the superficial organs like the thyroid and the breast, and the shear wave elastography, where there is mechanical vibration. So this is a quantitative means, and the acoustic radiation force impulses are used to generate the stiffness values. So transient elastography, all of you are using this, I'm sure. And only thing is, here you are unable to use in patients with ascites and obesity. The point shear wave elastography, where a very small region of interest up to 1 cubic centimeter is sampled, and the 2D shear wave elastography, where a large area of a large volume, 20 cubic centimeter, is sampled, but you can do real time and have a look at the masses and the large vessels. So moving on to MR elastography, it is reported to be the most accurate non-invasive imaging modality for the identification and staging of liver fibrosis. Large portions of liver are sampled. That is a great advantage of using MR elastography. You can combine it with diagnostic MR to provide the most comprehensive liver imaging examination. And but remember that the values that you get with MRE, you cannot just translate them into ultrasound values, and vice versa, because for ultrasound you are using the Young modulus method, while for MRE you are using the shear modulus method. So how does MR elastography, how do you go about doing it? There are two drivers. There is a pneumatic driver which lies outside the elastography room, and then there is a passive driver which is fastened onto the abdominal wall over the liver. So if you see here, this white colored disc, that is the passive driver, which is placed on the patient's abdomen. And this blue box, that's the active driver, which lies outside the MR room, and the two are connected by a polyvinyl tubing. So, the where do you place the passive driver? You place it over the abdomen, and is there any points which helps you to place it? The xiphoid and the mid clavicular line, and where they intersect, that is where you should place the passive driver. And this is over the right lobe of the liver. Sometimes you can place it on the right lateral abdominal wall, and then you hold in place with an elastic strap under the phased array coil. So the driver sends in acoustic vibrations at 60 hertz, and you can set the amplitude, which is usually 50%. If the patient is obese, you spike up the amplitude. If the patient is thin, you bring it down. It can also be varied according to the BMI values. But remember that low amplitude may result in low quality elastograms, while the high amplitude may make the patient uncomfortable because of the increased vibrations. Patients have to be fasting for 4 to 6 hours, and they are taught to hold their breath in end expiration, because that is the time you want the liver to be covered by the passive driver pulses when they are sent in. Typically, we obtain 4 sections of the liver, 4 elastograms. You avoid the liver dome because unnecessarily high values will be there. And if you also avoid the inferior portion of the liver, because this will result in chaotic waves. We do not have a 3D MRE facility with us, and most of the centers don't have it either. So, but if it is there, it is useful, because then you can look at the motion in all the planes, and there's less chances of failure of the technique. So a very busy slide, but all you need to remember is that either you can do a gradient echo or a spin echo. With the spin echo, usually with a 3 Tesla, and you get the acquisition in 16 seconds. On the other hand, up to a minute for a 1.5 Tesla MRE evaluation if you use a 1.5 Tesla MR scan. These are the images that you're going to generate. So you'll get a magnitude image, which provides the anatomic information. You'll get the liver outline, you'll get the aorta, IVC, and on the right is the phase image, which provides the wave motion information. But more important are these images that you will get when you do a MRE. These are the color wave images. So these are parallel images going from the surface to the inside of the liver. And the elastogram images at the bottom, you have a grayscale elastogram and then a colored elastogram. And if you look carefully under that colored elastogram, there is a bar which tells you, a color-coded bar, which tells you how much the scale, 0 to 8 kilopascals. So if you are getting more of oranges and red, then it is like orange color. This is more like 8 pascals. And if you get purple or violet, it is more like lower values. And then if you see, there's a checkered board that comes automatically with the read. So you have to place your region of interest outside that checkerboard. So to cover the liver, and you need to draw with a manual ROI to take the values of the MRE. So high quality waves form parallel to the outer surface of the liver and propagate unperturbed through the liver. And if there is wave distortion or wave interference, they do not move parallel through the liver or are disrupted, and this may give an artifactually high or low LSM. And on the images, you can see a high quality wave image and a low quality wave image at the bottom. When you are looking at MRE of a normal liver, remember that the normal liver parenchyma actually attenuates the shear waves more than a cirrhotic liver, and that is why sometimes you may land up having only a very small area outside the checkerboard to place your ROI and take the values of the MRE. Causes of a non-diagnostic elastogram are a significant iron overload, non-functioning active driver, or a disconnected tubing between the active and passive drivers. So as I said, draw ROIs and then do an arithmetic mean, and you avoid the vessels and the gallbladder fossa. And then there are certain areas which are the pitfalls where the driver is placed artifactually anteriorly, you can get a very high value, which is you need to ignore, because this is where the driver is placed. So this is a false hot spot that you get when using MR elastography. So when you interpret MR elastography, this is the values that you would take into consideration. Anything below 2.5 kilopascals is normal, and more than 5 kilopascals is stage 4 fibrosis or cirrhosis. And in between, you need to know this chart to put in where how much of fibrosis is there, label it as such. So if you compare these MRE values with the ultrasound elastography values, remember, as I said, the Young's modulus is 3 times more. So what we were saying is greater than 5 lands up greater than 15. And when we talk about the lesser values, if you compare the two, when we're talking about 3, it is about 7 kilopascals on the ultrasound elastography side. So there is data which shows that MRI has the highest repeatability, reproducibility, accuracy, and the highest success rate. It is the best diagnostic performance for significant fibrosis and cirrhosis when you are comparing it with all the other elastography techniques based on ultrasound. So the clinical application is fibrosis, follow-up of patients with previously diagnosed fibrosis. You could use it for actually benign and malignant distinguishing hepatic lesions as well, and looking at their response to treatment. So this is a meta-analysis which looked at the MR and fibroscan in chronic Hep B patients, and they found for all the fibrosis, whether it's significant, advanced, or cirrhosis, the AURC values were much higher for MRE versus the values for fibroscan, so showing an advantage of MRE over the fibroscan. Again, this is a study which looked at MRE versus the ultrasound elastography in patients with that time article named as NAFLD, and here again MRE has the highest diagnostic accuracy for stage 4 fibrosis. It has the highest reproducibility as well. So this is a meta-analysis which has in NAFLD, which has looked at elastography, ultrasound-based versus MRE, and they found that both MRE and point shear wave elastography met the acceptable performance levels for diagnostic accuracy for advanced fibrosis, and only MRE met the acceptable performance for diagnostic accuracy for cirrhosis. So as far as portal hypertension is concerned, only fibroscan comes in the guidelines, but there are studies to show that MRE has utility for predicting esophageal varices. Cutoffs like 5 kilopascals have been kept for increased risk of portal hypertension and esophageal varices. Chronic Hep C, again, LSM more than 5.8 kilopascals on MRE had a higher risk of decompensation in one study, and in PSC there are different values. So we at our center have also done a study of MRE in biopsy-proven MASLD, and here also we found that MRE demonstrated superior diagnostic accuracy in detecting advanced fibrosis stage within a high ORAC versus the shear wave elastography and the fibroscan. So these are just some of the images from our study, and if just you can look at the top 2 images. So when the good wave image, and you see the color coding for as per the bottom the color code, you can see this is less fibrosis. So this is was the F1 stage. But as we move on in the stage of fibrosis, the color coding in the liver goes from the purple, moves more towards the orange and the red, and this was F2, and here again it is F3. And if you see this last top 2 images, the color waves also have gone down, and also the color coding in the liver has moved more to the red color, increasing, showing increased fibrosis. So presence of fat will also not affect your evaluation. So this is a MASLD case showing the drop in signal intensity. And if you look at the color maps and the elastograms here, they were in the normal range, and it is corroborated with the histopathology that we had in this patient. So to conclude, MR elastography is a useful non-invasive imaging technique available for detecting and staging hepatic fibrosis. There is data which is saying that it is the most accurate, but in the scheme of things, I do not think that it fits in as the primary modality where we are looking at the stiffness of the liver. But it is definitely a one-stop imaging technique for chronic liver disease. And you need to optimize your imaging techniques. You need to have a quality control of images. As I delved into, you need to know which is a good acquisition, whether your waves are of high quality or of low quality, and you need to interpret it correctly, and you need to have a structured reporting for looking at the elastograms for MRE definitely. Thank you very much.
Thank you, Dr. Kara. Please join in this thing. We'll have the question answer at the end of the session.
So Madhumati is already there. So
thank you all. All right, my name is Madhumita Prem Kumar. I am an additional professor of hepatology at PGI Chandigarh. But that's okay. I'm Madhurima, Madhumita, all kinds of names, so that's fine. Why do you want to copy? Okay, so I'm here to talk about a new disease entity that has been called portosinusoidal vascular disease. And this is an umbrella term. Can it please be projected? This is an umbrella term that actually is comprising what was predominantly known as non-cirrhotic portal hypertension. The part that was idiopathic was INCPH. So you'll find a lot of data, especially from CMC Weller, which will say INCPH. Sometimes it would be called NRH, obliterative portovenopathy, whole lot of names. The disease is the same. These are patients with portal hypertension, but they do not have fibrosis, or they have a pre-sinusoidal form or a post-sinusoidal form. So there are a lot of disease entities that come under this umbrella term, but because the VALDIC, Vascular Liver Disease Study Group, has proposed this term, we in India, who have born and brought up with this disease entity, have to now follow and reformat our definitions according to it. So we'll briefly go over what PSVD NCPH is. So actually this idea has come from PGI and AIMS and these august institutions. It's a pathological diagnosis. So nodular regenerative hyperplasia, where there's no fibrosis, but there are these islands of proliferating hepatocytes which are making these kind of pseudo nodules. So it looks or appears to be cirrhotic, but there is no fibrosis. So the other term is hepatoportal sclerosis, because the portal vein is very thickened and the walls look arterialized. So it's a beautiful ultrasound finding. So hepatoportal sclerosis, even now at the bedside, we can diagnose it that way. NCPF, where there is non-cirrhotic portal fibrosis, pre-sinusoidal. So massive splenomegaly, young people. So that used to be there. Then IPH, incomplete septal cirrhosis. And now finally, after all of these terms, we are coming to PSVD in 2019. But it actually has all of these other names. They are largely synonyms. So let's see what it actually means. So the name changes, but the disease doesn't. It just has taken another form. But this is now pathological diagnosis, which means all the patients with EHPVO, which we just diagnose on the basis of imaging with a portal cavernoma, they have non-cirrhotic portal hypertension, but they will not meet criteria for PSVD unless you perform a biopsy. So should we biopsy those patients? Let's think about it. So we require a large biopsy. It should be at least 2 centimeters in size. There should be one specific sign of portal hypertension or one specific histological lesion for PSVD. So what are these specific histological lesions? Very simple. OPV, obliterative portal venopathy, nodular regenerative hyperplasia, that is NRH, and incomplete septal fibrosis. But please note, incomplete septal fibrosis cannot be diagnosed on the basis of a percutaneous biopsy or EOS or TJLB. You require a full explant liver to see incomplete septal fibrosis, because you require a whole lobule and a septum to actually talk about that. So what we can diagnose on the basis of our conventional clinical biopsies would be OPV and NRH. And other than that, there are other minor criteria which are sinusoidal or inflammation of vessels, abnormal periportal vessels, hypervascularized portal tracts. So we use these supportive criteria and come to a clinical diagnosis of PSVD. There are non-specific signs. Now, please look at that. It's ascites, platelet count, which is low, spleen size, which is large. This is there with every patient with portal hypertension. So it is really not specific for PSVD. So it should be non-cirrhotic liver, 2 centimeter biopsy, any of these histological criteria. And then one comes to a term PSVD, right? However, look at the fine print. PSVD excludes conditions that affect the hepatic veins, which means HVOTO, which we largely treat similarly because it's non-cirrhotic and it can also lead to cirrhosis later on. That does not come under this umbrella term. Okay, fine, let's accept that. Then other diseases which are causing microvascular or just pre-sinusoidal fibrosis like sarcoidosis, congenital hepatic fibrosis, we still see a lot of these cases. And SOS-VOD. They also are excluded from this umbrella term. So this is a narrow diagnosis of a histological entity which can have myriad clinical manifestations, and we need to see whether our Indian patients actually match up to these diagnostic criteria. So what do we see on histopathology? There's no fibrosis. Yes, there's some fibrosis in the portal tract area. Portal vein gets obliterated portal venopathy. There might be abnormal vasculatures in the portal tract, so abnormal irregular portal veins which branch herniations, beautifully seen here. And there could be nodular regenerative hyperplasia. So this is not a cirrhotic nodule. This is a nodule where there are a lot of budding hepatocytes. Because of the reorganization of the vasculature, they selectively grow in areas where there is fertilizer, or in this case, vasculature. Now, what we used to call NCPH earlier, we divided as pre-sinusoidal, sinusoidal, and post-sinusoidal as per our venography studies or our HVPG studies. So, pre-sinusoidal would have normal HVPG. So, in these, we would have arterioportal fistulas, INCPH, NRH, also some biliary disorders where we have a lot of portal hypertension and the fibrosis is inconsistently or not congruently as much. So that is seen in autoimmune cholangiopathy, primary biliary cholangitis, or even PSC. So biliary fibrosis is an exception to the rule of common cirrhosis. They have far more portal hypertension for the same level of fibrosis as is a hepatocellular disorder. We can also have neoplastic lesions which cause obliteration of the portal vein or its small vessels, especially with lymphoma. Sometimes we have these infiltrative kind of lymphomas, and we are now diagnosing a lot of PSVD in patients who have vascular disease because pathologists now know the term and they're reporting it more frequently. Sinusoidal is, of course, patients who have cirrhosis, but early ALD, early MASLD, early chronic viral hepatitis. It might be F1, F2 fibrosis, but they could have OPV, they could have NRH, so they will come under the ambit of PSVD. Can post-sinusoidal fit in? I already gave you a clue last time. Post-sinusoidal does not come under PSVD, but it would come under this broader umbrella term of NCPH. So we are excluding some and including others. With PSVD, we have excluded others and included some. I hope that makes sense. Is it vanishing? So we are seeing fewer and fewer cases of EHPVO these days, largely due to changes in economic status. People are not putting that umbilical vein gober, which used to be, or there are not as many exchange transfusions or umbilical vein catheterizations. But we are not seeing those pediatric cases, but we are seeing OPV, NRH, and ISH because explants provide a lot of ISH. They've been transplanted with a pre-operative diagnosis of cirrhosis, but they turn out to be NRH on explant or NCPF on explant. That happens very often, nodular NCPF, etc. And also we have a lot of drug-related. So CAM and herbal injury, when they don't have vanishing bile ducts, sometimes they have this vascular disorder. Things like azathioprine, again, vascular disorder related PSVD, and especially didanosine and zidovudine. Hard drugs are increasingly be associated with this. So a patient who's PLHA on drugs, if they develop a large spleen, we should start thinking in terms of PSVD. So the disease has not disappeared. It's just changed its phenotype and characteristics. So these are the immunological, drug, and thrombophilia related disorders. I think it's really difficult to see the slides when you're sitting. I apologize for that. I'll be happy to share the slides with all of you later, but please read it because this is important for us to know. So PSVD is actually a very large umbrella term. If you look at this Venn diagram, it could have clinical characteristics of what we used to call NCPF and ISH, or it will be histological. And then we have, and they all fit under PSVD, but we are removing HVOTO, SOS, and VOD. So it is actually a histological or a pathological dream. It is not a clinical dream because patients who present the same way are not meeting criteria for PSVD but would require the same treatment. So they would require treatment for bleeding varices. They will require treatment for ascites whenever it appears. They will also require treatment like anticoagulation. But we will not put HVO2 and PVT, even though we'll be anticoagulating both of them. They are vascular disorders, but PSVD says no to HVO2. So that's what it is. We can discuss this further. So HVO2 is out. So in this patient where we are having vascular block, it is also vascular disorder. It's non-cirrhotic. It is going to be excluded entirely. On the other hand, suppose you look at this biopsy, this is also non-cirrhotic. You see a whole lot of steatosis over here and not much fibrosis. A lot of steatosis, not much fibrosis, Mallory highline. Can this be PSVD? Yes, there is OPV sitting over here. Incidentally, there's a little bit of OPV sitting where that small arrow is. My pointer is not working well. So this would actually come in case you have NRH in one area and OPV in the other. This classical biopsy with MASLD will also be called PSVD. So lot of things to criticize here. So can this coexist in patients without cirrhosis? Yes. INCPH and MASLD cannot coexist, but NCPH, PSVD and MASLD can. I hope that is clear to the audience now. So this is data that comes from Vienna. So they looked at a whole bunch of about 1,000 biopsies, and about 908 of those were without cirrhosis, and 637 had no evidence of portal hypertension. They've excluded those. Finally, they have taken 104 who meet these clinical characteristics and pathological characteristics of PSVD. 4 are cholestatic disorders. So remember, PBC, PSC, they might come under this term even though they are cirrhotic disease but biliary fibrosis. Patients with HVO2 out. Patients with heart failure, again sinusoidal dilatation, also a vascular disorder secondary to chronic right heart failure, but will be excluded because this is post-sinusoidal. So patients with BMT, they have excluded. So finally, 91 patients they have got out of looking at 1,000 biopsies, which meet criteria for PSVD, but they are not cirrhotic. So you see, all patients without cirrhosis will not meet criteria. Maybe 10% of those, if you look carefully, would meet criteria for PSVD. So that's what the study says. So INCPH is a small subgroup of it when it is idiopathic and we don't know the cause. And they had looked at one more thing. They saw whether these patients have portal hypertension. Yeah. So is there any evidence of portal hypertension? And there's also a possibility that they don't have portal hypertension, which brings us to another layer in the diagnosis. We can have PSVD with portal hypertension, that is, if they have those histological criteria, but do not have evidence of varices, collaterals on imaging, so they are non-cirrhotic PSVD, but they don't have portal hypertension, which means these are incidental pathological findings. And then we have a whole bunch of patients which we know about, which is PSVD with portal hypertension, which would be like NCPF, EHPVO, etc. So another layer to this pathological diagnosis, which we have to accept as clinicians and we can criticize it. So in these 91 patients, 30% had fulfilled criteria. So only a third of them have portal hypertension and PSVD, which means there are about 60 of those who did not have evidence of portal hypertension at all. So these histological findings may be incidental in ALD, MASLD, CVH, but they don't meet PSVD criteria. Should we be treating them the same? I don't think we should. So patients who had portal hypertension and PSVD, they showed much higher CTP scores, though we should not be using CTP for patients without cirrhosis. They had a higher chance of developing decompensation naturally. They have clinical evidence or imaging evidence of portal hypertension, so they can bleed or they can have ascites, so makes logical sense. The mortality was similar, however, in patients who have portal hypertension or not, because you require a very long-term study because mortality is going to come maybe after 30-40 years. Liver-related mortality is slightly more. That means they would have died in case they developed massive variceal bleed. So that's how we would interpret this data. So in imaging, and I'm sitting here in between radiologists. So in imaging, naturally you would have a non-cirrhotic liver, surface would be smooth, portal vein would have that hepatoportal sclerosis, spleen would generally be very large, and you would have exceptionally large splenic vein, I would say, and a lot of collaterals and shunts. And on invasive imaging, we would have a normal HVPG because most of the time it would be pre-sinusoidal, or only the few ones which are sinusoidal will have a mildly increased HVPG. And we could have a few hepatic to hepatic vein comma-shaped collaterals. So what do you when do you suspect that the patient with MASLD or CVH or ALD, because they are with you, they don't have cirrhosis, they may have F1, F2 fibrosis, when do you think that they may be having hidden PSVD? So the clues are there in the imaging. If the patient has a disproportionately large spleen, if the patient has too much pancytopenia, or the patient has a very high platelet count in the presence of a large spleen, where you start thinking about a vascular or myeloproliferative disorder. So those could have OPV or NRH when we biopsy them. You can also do what we were talking about just now, splenic stiffness into liver stiffness ratios. And if the spleen is exceptionally stiff, that would suggest that this patient is likely to have PSVD. So here's a cirrhotic looking liver, extremely large spleen, disproportionately large, abnormal looking portal vein, multiple collaterals. So these are where in a patient of say HCV, if you see this imaging, you would want to think about PSVD associated with it. So how do you approach with elastography? So the same team from Valdeg is now giving more and more studies on it. So if LSM is less than 10, PSVD is unlikely, is more likely in a patient with portal hypertension. Between 10 to 20 is where you would actually do a biopsy for sure, because you cannot be sure whether it is early cirrhosis or it is going to be pre-sinusoidal portal hypertension. If it is more than 20, likely to be cirrhosis, maybe you don't biopsy if you know what the etiology is. So that's a simple way. What we are doing increasingly, and I really trouble our interventional radiologists for this, we do an SSM-LSM ratio. So if the SSM is twice as much as the LSM and the LSM is less than 10, likely this patient is going to be having excess amount of splenic congestion and therefore a possibility of portosinusoidal vascular disease. So we'll have to biopsy those people. So these are the radiological approach to PSVD with portal hypertension. And remember, we cannot diagnose PSVD without portal hypertension in absence of a biopsy. So it's an incidental finding. And we also don't know whether those patients progress to portal hypertension later, or those OPV NRH lesions just stay lifelong, like we find on autopsy, and it never bothers the patient. I think the latter is more likely. So how do we manage? Obviously, these patients have, if they have portal hypertension, we manage them for that. Maybe we might want to anticoagulate patients, especially if they are small vessel outflow tract obstruction, whether they are small abnormal portal veins. And of course, we would manage varices. I'll take 1 minute more. With TIPS, splenectomy, or shunt surgery like we usually do. So a lot of this PSVD is being diagnosed in explants where we are actually transplanting them with a diagnosis of cirrhosis or even HCC, and they turn out to be NRH on explant. That happens often. So liver transplantation is also being described in these patients. So how many of you knew about PSVD before when you walked into the hall? So everybody knew. I'm preaching to the choir here. How many of you think that pathologists know what they're talking about when they give a diagnosis of PSVD? Concordance rate is just 5 to 30%, unfortunately, as per all studies. And we know that there is this whole spectrum of disorders which are included or excluded. So is this PSVD or not? You're having this very variegated radiologist. This is not PSVD because this is likely to be HVO2. So HVO2 is not PSVD. Take a look at this one. This is a 52-year-old patient and has come with acute abdominal pain. Focus on that acute thrombosis of the portal vein that just passed. Massive spleen. LSM is 11. PSVD or not? Well, we biopsy this patient later because she underwent a TIPS PVR and it turned out to be cirrhosis. So not PSVD, but did not look so bad. If you look at the imaging, it wasn't so bad. Again, this is a 12-year-old child with acute viral hepatitis, massive splenomegaly, 18 bilirubin. PSVD or not? Hepatoportal sclerosis, massive spleen, collaterals. PSVD, yes. How many people? Very hesitant. So people will be hesitant because nobody knows about this. No, it's not PSVD. There is fibrosis on biopsy. So there's no way one can tell. One would have to biopsy these patients. So umbrella term, we are not sure whether it is actually valid for Indian patients at all. Please remember the biopsy is 2 centimeters, whereas imaging, especially if you're doing LSM, SSM, would look at a larger area of the liver. So you have focal fibrosis of the liver, you might misdiagnose it as cirrhosis, whereas the rest of the liver is okay. Or if you biopsy from an area with NRH. So the treatment would be different depending on whether there's portal hypertension or not. My take home is it is not going to change the way we manage our patients. We are still going to be treating them. We have been treating them successfully since time immemorial. It's just a change of names, but a change of name is fashionable because MASLD is there, NCPH is there. So, we just want to have another name. Thank you so much for your patient listening.
Thank you,
And my
Dr.
name also
Madhumita.
changed.
Yeah, thank you so much for excellent
Madhumita,
talk.
stay there, sir. There'll be questions for you.
Okay.
Questions will be asked
At the
after
end.
Acha,
at the
there's
end,
one
sir.
more.
Yeah.
Sorry.
So for the next talk, I'm inviting Professor R.K. Dhiman. He'll be speaking on EHPVO and portal carcinoma cholangiopathy regarding endoscopic management. Professor Dhiman, please.
Acknowledgements to Dr. Saraswat as well as the Nageshwar Reddy. He helped me as far as the endoscopic treatment is concerned with the slides. What is the definition of the portal cavernoma cholangiopathy? It was the INASL consensus that we did in 2014. Abnormalities in extrahepatic biliary system, including the cystic duct and gallbladder, with or without abnormalities in its first and the second generation biliary ducts in patient with the portal cavernoma. Three things that is required: presence of portal cavernoma, cholangiographic changes on either on the ERCP or on the MRCP, absence of other causes of these biliary changes like bile duct injury, PSC, and the cholangiocarcinoma. As far as the clinical presentation is concerned, the most of the time it is the asymptomatic, but there are so many biliary changes, there is no symptoms. Might be some elevation in alkaline phosphatase, but with symptoms there are the two types. One is the chronic cholecystatic, likely to be caused by the biliary structures, and another biliary pain or acute cholangitis, likely to be caused by the biliary stain. You know the stricture that could be either by the compression by the collaterals, or it could be the ischemic strictures also. So as far as the frequency of PCC is concerned, on ERCP it has been reported between 81 to the 800%. As far as the symptoms is concerned, it is around 19 or 20%. And most of the time you see that the symptoms are because of the gallstones or because of the common bile duct stone. Gallstones, they are present in around half of the patients, and the CBD stone in about quarter of the patients when we compare with the asymptomatic patient. So coming straight to the endoscopic treatment, there are many, starting with the nasobiliary drainage, especially for the cholangitis, endoscopic sphincterotomy and the stone removal, mechanical or the laser lithotripsy, stricture dilatation, then stent placement also, and nowadays we have fully covered SCMS. So this is the cholangiogram that you can see. There are stones over here, filling defects. They are looking like the stones, and we performed the endoscopy, then sphincterotomy, and then we take out all the stones. I think the question is always whether this sphincterotomy in these patients is safe or not. I would say it is safe, provided the INR platelet counts they are normal. Spyglass cholangioscopy that I would like to show to over here. You can see uh, there are small stones also, and the debris also. You can clean it. So there is a great role of the spyglass nowadays. Here you can see the laser stone fragmentation over here. That is the common bile duct stone here. They are the largest stones, and you can break them with the laser lithotripsy, and at the end you will see that there is the CBD is entirely cleared. You can see the laser. So the CBD, it is clear. I think there is a great role. Sometimes you cannot break the stones with the usual way. You cannot take out if there is a large stone, and if there is a biliary stricture, then you can dilate the stricture. You can go above it and you can do the endolithotripsy. Here you can see the one patient that has basically the biliary strictures also and the full of the stones here. So they have put, I have taken this figure from the article published by the Nageshwar Reddy also. The stricture was dilated with the SEMS, fully covered SEMS, and you can see here that just above the stent they are clearing the stone, and in the second one in the here it is at the hilum, and here they are cleared over, and you can see the cleared CBD also. So nowadays there is a role of putting these fully covered self-expanding stents. The stricture is dilated now, then you can go above the stricture and you can fragmentate all these stones also. The management of the biliary stricture, nowadays the people are putting the self-expanding stents also, but before that we used to put the multiple stents. That here is the biliary stricture here, which is being dilated by the balloon radial force, and after that you can put multiple stents. Here you can see the two stents on the right side and the stent in the left side also. And after 3 months or so, that you can put two more stents, so there are the 5 stents, and you can stents can be remained over there for next 3 to 4 months, or you can put more stents so that the strictures is dilated. So in the initial phases we used to put multiple stents. Here is the one patient with the Meryzi's stone in a patient with the portal cavernoma having portal cavernoma cholangiopathy. You can see over here this large meniscus that we have seen on the MRCP. In this patient, what we do the ERCP and we place the stent. You can see here the stent placement, and the LFT normalized, cholangitis subsided also. After that, there was a the CVD repair over the T tube, and after the removal, the patient was asymptomatic. So this is the way it is nothing that our treatment is basically patient oriented. The patient presentation also. Here we have the Meryzi syndrome. First we have done the endoscopy and followed by the surgical repair. Here, this is the PCC for the biliary stricture. The stent was placed. It remained there for about 3 months, and when the stent was removed, you can see over here is spurt of the bleeder that is coming in from the inside the CVD, and it was most likely because of the bleeding from the choledochal varices. You can see here over the guide wire we place the metal stent over here, self-expanding, and because of the pressure over the varices the bleeding is stopped. Fully covered self-expandable metal biliary stent for the biliary strictures. Here there are multiple case reports, case series is also, where initially they have placed plastic stent after the sphincterotomy. There are the few for the biliary CVD stenosis, and for the stones there was endoscopic sphincterotomy, and sometimes you have to place the stent if there is a associated stricture also. But recently, as I have just told you, that the stent fully covered SCMS can be used for if there is a choledochal variceal bleeding also. And there is one recent study that is published in 2023 for the CVD stones stenosis. All patients have this stricture, but in 4 there was additional CVD stones above the strictures. What they have did, they placed the SCMS in these patients, and then they clear the stones in 4 patients, but in remaining patient it remained there for 3 to 4 months, and they have removed the stents, and they have seen that there was a dilatation in the CVD strictures also. But in 7 patients there were the episodes of the acute cholecystitis that was just self-limiting. Problems with the endoscopic management, bleeding during the endotherapy that I have told you, hemophilia is there, but it is very uncommon. Intracholedochal varices masquerading as the filling defects may be the source of the bleeding during the balloon trawl or basket sweep of the common bile duct. What happened is there is a multiple choledochal varices inside the CBD, and you inflate the balloon above it. You can see over here, if you inflate the above and then you sweep over here, then you can see there is a dilatation of the varix at the lower end and they can rupture also. I think this has to be kept in mind also. And another thing is that sometimes if you are using the dormia basket, you can catch them also, and that can cause the hemophilia also. I have just told you plastic stent, if withdrawal, then there can be bleeding also, and this bleeding can be controlled either with the terlipressin or the nitroglycerin infusion, causing some nitroglycerin infusion, basically lowering the blood pressure, systemic pressure. But nowadays the fashion is for the insertion of the FC SMS in these patients. Cholangitis. This is the commonest complication during the course of the endotherapy and encountered in patients who undergo repeated endoscopic procedures over a prolonged period of the time. Most of the, what is the cause? Incomplete clearance of the calculi or debris above the stricture, that is the most common. If the stricture and the stones both are present, or there is a delay in plant stent exchanges in the poorly compliant patient. You ask the patient to come after 3 months and he is coming 4 months and presenting with the fever, jaundice, or classical symptoms of the cholangitis. So this is the one common thing when you are having the multiple sessions of the ERCP. May result in the serious complications such as the cholangitic liver abscesses, ruptured abscesses, and sepsis, all these things. I like to conclude, and the conclusion I have taken from the INASL consensus on the PCC, what it say? Nasobiliary or biliary stent placement for the acute cholangitis is safe. I think you can go ahead. In presence of the normal platelet counts and the normal coagulogram, biliary sphincterotomy is absolutely safe. Very rarely we found some kind of the bleeding, and that is managed, I think, with the compression. Biliary stricture dilatation and stent placement is a safe procedure, and the strength is although weak, but the evidence is a moderate. Biliary stricture dilatation and the stone removal after lithotripsy may be performed safely. At that time, there was not much experience with laser lithotripsy and other things, as well as the covered stents also. But nowadays, these procedures, they are coming, and more literature can be seen on these topics also. With these, thank you so much.
So, after listening to Sir about endoscopic management of portal cavernous we have Dr. Amar Mukund. He will teach us about radiological management for the same. Thank you.
Can I please request someone from audiovisual to connect the...
So explant liver or whatever you do a biopsy, the fibrosis will be on HNE, Mason's trichome, or Cyrus red. Or seen also. So everything. And what about chicken neck appearance in people taking alcohol, a bit of alcohol?
So exactly. So that would not be quantified as cirrhosis. There will just be F3 fibrosis if there's chicken wiring. So even in MASLD in patients with alcohol, if we don't have proper bridging fibrosis and there's just some chicken wiring in some areas of the biopsy, and we have OPV somewhere else, and we have NRH somewhere else, this is definite criteria for PSVD. So the treatment is for PSVD or it will be for ALD. The answer is for ALD.
I go more confused.
Yes, I agree that it's confusing, and we have to stand up and say it is confusing and even wrong. So if you have chronic viral hepatitis, the patient has viremic HCV, we are having OPV and NRH, there's no cirrhosis, there's some portal hypertension on some imaging. Dr. Amar Mukund has found a collateral somewhere rather than his slides. So that is going to be PSVD. But the treatment would be DAs. We won't be so worried about. Yes, sir.
So we'll have questions.
I was a resident. We were very clear.
So we are also very clear, sir.
Our teachers used to teach us very clearly. There is no cirrhosis. There is portal hypertension. This is non-cirrhotic portal fibrosis.
Completely.
Autopsy studies, we are not getting. There have been autopsy studies. Multiple autopsy studies. Because there is no treatment for portal hypertension.
Sir, can we? He's ready with the slides, I believe. Amar, are you ready?
Yeah, ready.
third one EHBBO, and fourth was hepatic venous outflow obstruction, fifth was cardiac.
250 microns HVTO.
Now, just because a group of people said, why you want to get confused?
We are actually getting together to offer a rebuttal. So if anybody in the audience belongs to a site who wants to contribute to this data, around 10 centers across India have already contributed data. If anybody wants to contribute, please get through to me.
Okay.
Yes,
Okay.
James has-
We can have the discussion of that. Go ahead.
Yeah, so thank you, Chairperson, and I would like to thank INASL and organizers for having me here. So I'll be talking about EHPVO first, and portal cavernoma cholangiopathy has already been covered nicely by Dhiman sir, and I'll be adding very minimal to it. So with this, as we all know that patients with PVT would gradually develop periportal and peribiliary collateral channels, and that is cavernoma, and this is to maintain the splenomesenteric flow. But these cavernoma may not adequately decompress the system. So that is one of the problem. The first problem, it doesn't adequately decompress. It decompresses. That's why they are asymptomatic. That is what we know. That's why they are asymptomatic. But they will lead to some of its complications. And they further compress the bile duct and lead to development of biliopathy. That again has been discussed, but it may be reversible and irreversible, and the reversible cause is just a compression, whereas there are ischemic causes when it becomes irreversible. And what are the causes for irreversibility? If there is a long-term cavernous dilatation, neoangiogenesis, and deposition of fibrous tissue over the bile duct, they do not revert even after shunt surgery. So if we recanalize, do shunt surgery, whatever we do, it is not going to revert. Secondly, if there are bile duct strictures, which is secondary to ischemic changes, which generally happens following venous damage at the time of portal vein thrombosis. So as soon as portal vein thrombosis is there, small venous channels, arterioles, they all get into ischemic state, and that leads to the injury, and mostly it is at the ampullary level, and that's why we see that the bile duct is dilated but the ampulla is always constricted. So that is how it leads to cholangiopathy, and those are not reversible. However, if we come back to the first problem, that is extrahepatic portal venous obstruction, so that is what we have been discussing, PSVD, EHPVO. But yes, let us stick to EHPVO, not an umbrella term. Exactly, yes, portal vein is thrombosed. So best way to treat these patients is by restoring the portal flow, by recanalizing these thrombosed or fibrosed portal vein before the irreversible changes takes place. So yes, if we recognize this disease at an early stage and we know that we can open it, probably that's the best way to go about it. And recanalization of portal vein will thus relieve the portal hypertension, disappearance of collateral channels, and either there is a resolution of portal biliopathy, or at least it will make the patient suitable for the surgery, which will be less risky, and probably will have a better results. So this is one of the algorithm which we, after studying a lot of cases, and then we thought probably in today's era, how should we go about it? So as soon as we see a patient with EHPVO, we should look and evaluate if there are any recanalizable portal vein. And if there are a recanalizable portal vein, and it is a non-cirrhotic case, as we have been discussing in this session, just recanalize the portal vein, put a stent, open it. It is a non-cirrhotic liver. You don't need to put a tips along with it. If not, maybe mesorex bypass, which we generally consider in a pediatric age group, but there are reports from adults from European nations where they do mesorex bypass for surgery. So probably again, new thing coming up. I don't know how surgeons will take it, but yes, if that's possible, maybe taken up. Not possible, then portal vein recanalization tips, because if it is not possible, that means the disease has already progressed. It has gone to a level where there will be some fibrosis, and if there is a fibrosis, yes, probably we are justified in creating a tips along with recanalization. And here, because there is extent of thrombosis and fibrosis is higher, so you need to actually decompress the system along with recanalizing it. So we go into the portal vein, recanalize the portal vein, and then we connect it with tips. If again that is not possible, then maybe we are in a very advanced stage. Again, there will be a lot of discussions regarding transplant versus non-transplant. But if you don't go towards the transplant, probably you can go and do a collateral tip. So sometimes you will find a big collateral, maybe 7 mm, 8 mm, 9 mm, 10 mm, and you can connect those collateral and decompress the system and maybe get away with some of the complications of portal hypertension. Even if that is not possible, people are now doing extrahepatic portosystemic shunts, and that is directly from SMV or splenic vein. So this is known as mesocaval shunts. So there are techniques where they take fluoroscopy as well as CT guidance. They create a channel from IVC up to that SMV, and they direct that shunt. So these are different ways how we can tackle. So this is the algorithm which may be followed if feasible. Otherwise, we can stick to the surgical treatment what we have been doing, that is the PSRS along with splenectomy, with devascularization, with hepaticojejunostomy, and so on and so forth. So what are the IR options for EHP view? So if we look at the IR options, then it will consist of portal vein recanalization, then portal vein recanalization tips, as I mentioned, and again there will be multiple routes to do this. It consists of transjugular, like we do a normal tips. It may be transhepatic and transjugular. It may be transsplenic. You take an axis from the splenic vein. Not possible, transmesenteric. People can do it from SMV. From SMV, you go all retrograde into the portal vein, recanalize and put a tips. And sometimes you may require a multiple accesses right from portal vein, splenic vein, and you go connect all and put a stent. Then we can do a mesocaval shunts, we can do a collateral tips, and finally, if nothing is possible and patient has already landed into cholangiopathy, then probably yes, we have to do what we can offer is PTBD if ERCP fails and probably there is a hemophilia, recurrent cholangitis, or a patient in a cholangitis where ERCP may not be feasible because of a general condition. Probably PTBD will help, and again we can go back to recanalization thereafter after the stabilization of the patient. I'll show you some cases like portal vein recanalization. Who are the cases who are suitable for portal vein recanalization? So this is a young lady, 26 years old. She came with 2 episodes of bleed. Nobody knows why there was a bleed. The LSM was normal, as Dr. Madhumita told. Even spleen is not very big, though it is enlarged. It is 14 centimeter, not very enlarged. SSM was high, yes, because it is a congested spleen, would be high. What do we see? On CT scan, we see a cavernoma formation, we see a dilated portal vein, but dilated CBD. But yes, these patients generally do not have any symptoms of biliary obstruction. So after seeing that, we did an ultrasound, and on ultrasound, we found that there was a portal venous. The native portal vein was also seen along with various collaterals. And we injected a contrast with a pressure. What do you see? This portal vein is actually as good as a normal native portal vein, and it is obstructed just about 2 centimeters from the formation, from where it bifurcates into right and left. So we further tried, and it takes a while. It is not a, simply you just insert a wire and it will go. So it takes a while because you will keep going into some of the collaterals channel in between, but you have to, be consistent and try to get into the portal vein. You may cross this portal vein, go inside, and once you take a run, again, you will find so many, overwhelming collaterals and varices all around. So it may be a good idea if these patients are bleeding, you can go and embolize these collaterals first. So at least get rid of the one which is bleeding, and once you are sure that you have embolized and you have made this area free of varices, then you can take care of this portal vein. So we did a balloon dilatation. You may require to do a serial dilatation, but you will find that most tight stricture at the level of lower part of the portal vein where there is a confluence, and thereafter you find that those are soft strictures and not very tight strictures. And this is again after multiple dilatation, serial dilatation, we found that it is persisting, the flow is not very good, so you may require to put a stent. And after putting a stent, there is complete, you don't see any collaterals, and we have taken a run from splenic hilum. So we are not taking it just proximal to the stent to show that there is no collaterals. Yes, it has been taken from the splenic hilum and all the flow is coming, but there are no collaterals. So once you nicely open up the portal vein, there is the collaterals do vanish. And this is the reversible case where you just open the portal vein and you have treated this EHPV. But there are conditions where this may not happen. There you would require to do a portal vein recanalization tips, and I'll show you an example. This is in 2020, just for the reference, I have kept this image like this. You can see again extensive EHPVO with a massive spleen reaching up to the pelvis. And after 3 years, this patient developed ascites. The patient had episode of bleeding, and the patient had jaundice as well. So when the patient was offered a treatment in 2020, the patient was not happy because the patient was asymptomatic. And after 2 years, the patient became symptomatic. And in fact, now the portal vein, intrahepatic portal veins are very much diminished. But and even the ultrasound picture was not very good. But still we went ahead. So we start, as a rule, we start from transjugular, though it is said that transsplenic, transmesenteric and other accesses may be taken, but as these patients have low platelet ascites, so it is always good to be on a safer side. And somehow we do good ultrasound guidance from transabdominal side, like Dr. Kalwa said. They use intracardiac echocardiography. We do it transabdominally, and we have a very good view from ultrasound. So we tried, and we entered into multiple collaterals. You will see we are entering into different collaterals, and these are not the native portal vein. The signature portal vein is not there. But fortunately, we hit one of the portal vein, which was the native portal vein. And this is the typical branching pattern, although it is all attenuated, diminished. So once you see this, so this gives you a confidence, okay, fine, you have gone into one of the portal vein branches. And then again you start poking, you try negotiate your wire to get into the distal part, into the splenic vein, into the SMV. And that is what we did. We went into the splenic vein. But again, as we know that the flow is directed through the collaterals, this is how it is flowing. Everywhere it is collateral. So we dilated this whole segment, and this was a long segment stricture where the splenic vein, the portal vein, the confluence, everything was involved. We went into the SMV, then again SMV was also involved. We did the same. And after doing multiple ballooning, we placed a TIPS stent. And after putting a TIPS stent, again, we see that the collaterals are gone. So doing, it is a time-taking procedure. You have to keep persisting, trying to go into both the feeders, the superior mesenteric vein as well as the splenic vein, open it. And this is a follow-up. That was in 2023 when we did the procedure. This is in 2024, 1 year follow-up. We see TIPS is patent. There are no dilated biliary radicals, no ascites. So these patients actually do well. So we need to understand where we can just open the portal vein, where we have to put TIPS. And sometimes these are the patients, very advanced case, where you have a big collaterals, but probably these are not a case where you can, because you see big chunky calcification, it is a very fibrotic. Though we didn't plan a collateral tips, we were trying to do a PVR tips, we failed, and then we did this collateral tips, and then we learned that yes, that is also one of the way of treating it. And once we did, we saw that the ascites was gone and there were no further episodes of bleeding. So yes, these things do help. And this was way back in 2015 when we were just trying to do some portal vein recanalization. So coming to portal biliopathy, so what are the IR options? So PT-BD may be done to treat cholangitis or for stone extraction, especially in patients with failed or abandoned endotherapy, as sir has nicely explained, and I won't go into the detail, because wherever there is uncontrolled bleeding and if fully covered metallic stents are not available, at least the patient has to come out of the cholangitis, and we need to drain the system first, make the patient stable, and then we can do further things. Just to quickly show you one of the example, this patient was undergoing multiple sessions of ERCP, later underwent splenectomy and PSRS along with biliary enteric anastomosis. However, because as I said, these patients may have ischemic stricture, we saw multiple stones here. and then we had to do PTVD 1, 2, 3 dilatation, and we can do stone clearance as you do. It is just like we push the stone, you pull the stone. So this is the difference. And nowadays even cholangioscopic devices are available for percutaneous procedures, and that can be done. And this is after repeated sessions of balloon dilatation and stone clearance, like we are getting rid of catheters one by one, and finally we could make it clear. But these are cases where follow-up is very much mandatory, because this will come again. This is not the end of the story. This we did in 2018 and 2022. Again, the patient came back. So yes, these patients will keep coming back to you. So with this, I come to the final slide. IR therapies have shown a tremendous evolution in the management of EHPVO over the last decade, and they include portal vein recanalization and portal vein recanalization tips. Finally, PTBD and stone clearance may be done for patients with persistent cholangitis wherever ERCP fails or wherever surgery has been done, the anatomy does not permit to do a ERCP. Thank you so much for your patient hearing.
Invited comments from the audience, comments, criticism. Dr. Kalra, you started with saying that you get only a small bit of liver in liver biopsy, and you're comparing your study with liver biopsy. That's a gold standard for you. Isn't that a paradox?
We have no choice because we don't do explants. So that still says.
But you started off with that that's the fallacy of a liver biopsy. I agree with you.
Only we are comparing, other modalities are also comparing with liver biopsy, and we are comparing those results of ultrasound, SPE, we are comparing, we are doing that in the same set of things. So,
and secondly, what's your hunch if you add MRS to this?
that will not, for the fibrosis, it doesn't give any information.
Maybe some spectroscopy, something is different in fibrosis.
Tell you about the composition, the chemical composition, but it will not give any information about the stiffness. It doesn't work for stiffness of the.
But somebody has to do it and show that doesn't work or it does work.
That is a proven thing.
For MRI, it doesn't.
About the chemical composition. It doesn't show about the.
So we have plenty of. Abba, please go ahead. Can you have the microphone, please?
Sorry. So, what was the spectrum of patients in which you were able to recanalize, and how many of them were idiopathic EHPVO? Sorry, idiopathic EHPVO as we know it in pediatrics. That means kids which have had an early block and there is a large cavernoma, usually knocking out both the left and the right portal vein. So how many of those your patients were that variety? Because as I understand, recanalization of the portal vein is next to near impossible in this kind of patients in which the type D or E anatomy is there. It's only if there is a type A anatomy, sometimes in BNC you can recanalize. So which anatomy, this kind of anatomy, we do not see in EHPVO in kids?
Yeah, so a wonderful question, and for that we need to pick it up early. So that's the key, how early you pick it up. But sometimes even if you pick it up very early, still it is not possible, because it is in the time of infancy when you see these cases. So it may not be possible. However, if you ask about my experience, we have a 50% chances where we have recanalized. And I'm happy to tell you that my maximum experience with EHPVO only for portal vein recanalization is with pediatric patients only. For adult patients, we mostly go for PVR tips rather than only PVR. But as far as pediatric patients are concerned, we are doing, and we are not putting stents also. Many times we do a repeated session. So there is a kid which is already, who has underwent 3 sessions of portal vein recanalization, because after a year, again we see that the portal vein gets down in size, the caliber reduces, and again the collateral size increases, and again we go back, we balloon dilate it, and we don't put a stent, because these are growing kids. So yes, when we started, we had a 70% success. It came down to 50% because we are not successful in a whole lot of patients. But yes, there are good number of patients, and that you need to evaluate properly based on your CT scan, ultrasound, and sometimes you have to do venography, retrograde venography, to look for portal vein radicals, where you do see a type 3, type 4 blocks. And even these strictures, as I showed in the images. Many times the stricture is very tight at the level of the confluence, but thereafter, as you go inside, they are not as difficult and as tight as it is at the main portal vein level.
Abha?
My question is, what is the natural history of portal cavernoma cholangiopathy? We have patients who had a shunt, but the cholangiopathy persists, but they're totally asymptomatic. The LFTs are bang normal, but there are stones in the liver. What would you do to this patient? Would you intervene? And we've been like following up this patient for years.
If you look at the different presentations on ERCP or MRCP, so what you are telling, the intrahepatic stones,
Yes.
and few changes in the extrahepatic biliary system. We called it that an ectasias actually. More on the left side, but could be on the right side also. In these ectasias, there is a bile stasis also. So therefore, there is a formation of the stones. I'll give you example. Sometimes these ectasias, they are in connection with the common bile duct. In that situation, you just go and put a metallic stent over there, fully covered. And once it's dilated, then you can go cholangioscopically and you can remove these stents doing the lithotripsy, or just leave it. Once it is dilated up to the 10 millimeter, then these stones, they passed out. But sometimes you may not be able to connect it. And in that situation, you have to do partial hepatectomy sometimes in these patients also. But endoscopy is always the first choice to take them. I'm sorry.
Never mind. Can we be brief? We're getting late. Dr. Anand, very brief.
Not a very important question, but Dr. Kalra, I have a question for you. You presented data to say that MR elastography is very objective and it's a very accurate area under the curve 0.95 to 0.99. But when you were concluding, there was no conviction in your recommendation that it is going to be useful. Why is that?
Yeah. So yes. So sir, I duly acknowledge your statement here. My only thing is, if we are saying it's a very accurate, there is data to prove that. So there's published data.
No, he was very modest.
So
that's
the only
all.
thing is, do you think? I don't think it will find a place in the practical utility when we talk about MRE. So if patients refer to us for MRE for fibrosis, I'll not be able to give table time to 10 patients in a day. So that is the reason I didn't say that it is a very accurate technique. But in the scope of things, practicality, if you look at it, if you want to include it in your evaluation of patients for fibrosis, I don't think it's a very practical approach to do it. It's good when we are looking to prove some therapies, when we are looking to do some trials, but for routine patients, there is no doubt about its being the most accurate technique as far as data is concerned. So, as sir said, I have a slide where it says that, but before coming here, I actually made a change in that slide to say that it is a good overall one-stop imaging technique to look at chronic liver disease. But if you want to bring it as a practical usage, I don't think personally that it is feasible to do it.
I think you're confusing the public health issue and the individual health issue. From public health point of view, every patient may not be able to afford it, may not be able to reach it, may not be able to get it done. But there will always be people who will come to you for this and they'll get it done from you.
Sure, that is definitely. If you want to say that, if
They're
you
all
want to
welcome
have
to
a
come.
method,
They're all welcome. Sorry, sir. I'm sorry. We are getting late. I'm sorry. We can't have your question. So we're getting late now. Thank you very much, all the speakers and my co-chair. And we close the session now. Can we have all the speakers on the dais, please? Madhumita, on the dais.
Yes.